Participants, I would like to start our session on the spine. Here I would like to welcome Dr. Stipe Čorluka from Croatia, who will give us an introduction, so the history, basic concepts and principles of the spinal surgery. Thank you.
Thank you, Marko. Thanks to FORTE and FORTE for giving me an opportunity to present spinal surgery. As probably you think, it's not so interesting field of orthopedic and trauma and also neurosurgery, but I consider it really interesting and really demanding, and I'm enjoying performing the spine. So I'd like to warm up you with how important the spine is today. It's raising awareness of the spinal, especially spinal degenerative conditions. So have you ever heard about texting, not sexting, texting neck? So I'll do you a favor, leave your phones aside, and you can say thank you later, because you will have your healthy neck. Just a little bit about my disclosures. I have some consultancy fees, but nothing related to this presentation talk. Who am I? I'm orthopedic and trauma spinal surgeon and proud our Spine Knowledge Forum Degenerative Associate member, where I lead some topics through the three big studies. And I work in Zagreb, in Croatia, at Spinal Surgery Division and Department of Traumatology in University Hospital Center Sestre Milosrdnice in Zagreb, capital of Croatia. We are the largest spinal center in the southeastern Europe. We have traditional spinal surgery for more than 50 years. We have a ward with 31 beds. We are performing 800 spinal surgeries per year, 10 to 15 instrumentation procedures per week. We are 5 orthopedic and trauma spinal surgeons, and we perform full range of adult spinal pathology, exception of intradural lesions. And we are performing all surgery techniques, so you can ask me about almost everything in spine. What's the spine? Spine is bony, cartilaginous, and ligamentous structure which makes a connection with upper and lower part of the body. It provides many muscle groups provides additional stability, and spine provides stability of the neck, trunk, and pelvic ring. It has a protective role for spinal cord and nerve roots in spinal canal. When we consider history of spinal treatment, we should go to ancient Egypt, where is found on the Smith papyrus observations to determine the presence of dislocated vertebra. And they made a connection and relation with spinal fracture and loss of feeling in the legs and arms or paralysis. Hippocrates described spine deformities. We know that probably the whole orthopedic surgery is developed by the spinal deformities, and he developed treatments involving contraptions known as Hippocratic ladder and the Hippocratic board. Galen correctly described spinal column. First surgical recordings are from about 200 years ago. First laminectomies for decompression procedures, and they usually did not go well with severe complications. In the early 20th century, Hips performed first fusion surgery for deformity correction in tuberculosis case, and in 1932 there was a first intentional discectomy by Mixter and Barr. During the mid 20th century, techniques are developed, implants and indication for spinal surgery conditions. And then we are coming to nowadays. Now we have, in the last 30 years, there are developed many minimally invasive spinal surgery techniques. We have modern navigation systems, and nowadays we have endoscopies, even third generation of biportal endoscopies. What's the basic concept of spinal surgery? We are treating humans, not radiological images. Patients are visiting me that were proposed by other surgeons for some kind of surgery. It doesn't matter if it's a neurosurgeon or orthopedic and trauma spinal surgeon. They see their MRIs, there is a disc herniation. Yes, you're a candidate for a surgery. We are treating humans, not images. You must take through an anamnesis, then examine the patient, find clinical findings, then make an insight into imaging and find a correlation. When you have that connection, you must propose treatment modalities. Most of spine conditions can be treated by conservative methods. And don't force technique over indication. If you are used to do, I don't know, endoscopy, not all patients are candidates for endoscopies. Not all disc herniations are suitable for endoscopies, and vice versa. Not all conditions are for open procedures. You must consider all factors that are impacting your decision. What do we treat surgically? When we have to treat something surgically, we have to treat three main components. You must be aware of them. First component is pain. That's why mostly patients come to your office. They have pain. Then they can have some kind of deformity. It can be deformity in the childhood, but it can be degenerative deformity or traumatic or tumor deformity or infectious deformity. And last but not least, and most important, we are treating neurological deficit. If you have some neurological deficit, you must find it on the imaging, and you must tailor your treatment plan. Nowadays, we are talking about sagittal balance. We are considering that we are not equal in this room if we talk about age or anything. So we are not equal in our spines. There are five types of spine of Roussoli, five types of spine with three types with low grade and two types with high grade pelvic incidence. Some of us are more loaded from the front. Some of us are more loaded from the back. Therefore, we have the cone of economy. Has anybody heard about cone of economy? Can you raise your hands? One. It's one of the most important things when you are treating a degenerative spine. Either cervical, either lumbar spine. Thoracic is not so usually treated for degenerative conditions. It's just some kind of calcified thoracic discs. So, cone of economy. I will talk about cone of economy a bit more. Cone of economy during the hip spine syndrome. The wider is the base, the more energy you need. The more energy you need, you are closer to the surgery. So you must always, and you as a surgeon, if you are seeking for a spinal surgery, if you want to be a spinal surgeon, always take upright X-rays, because MRIs are always in late position, okay? Do you know why? Can I have an answer? Why is most important upright X-ray? For example, you have listhesis on MRI. What do you expect on upright X-ray? You expect to see if there is any slippage, more slippage than on MRI, so you can compare. And then you can say, okay, this listhesis is unstable or stable, because there is no scientific proof of stability in degenerative spinal low-grade listhesis, first or second grade. What techniques do we have? We have really open and rough techniques. This was my patient 3 years ago. He had some kind of tumor. First symptom of malignant disease was spinal metastasis. I had to decompress widely. I had to put the screws. Sometimes there is a favorable condition to treat it minimally invasive by spinal endoscopy with an instrument which is like pen. And I had disc herniation extracted by endoscopic technique. So we can be combined. This tumor I treated minimally excess. It's minimally excess surgery. I treated it with percutaneous screw in minimally invasive manner, but I had to decompress it and make to reduce the tumor mass by open procedure. So we can combine. So now maybe you can find spinal surgery more interesting. Then approaches. We can do it anteriorly. You can see this was a 39-year-old lady with with cervical kyphosis treated with anterior platen cages, and we had the anterior approach. Then, sorry, this is a picture of this should be the last picture, but okay. So we can go lateral on the lumbar spine from the flank to put the cage in minimally invasive manner and put the percutaneous screw. It's an X-lift, L-lift, lateral lumbar interbody fusion. And we can go to anteriorly to the lumbosacral junction. also in minimally invasive manner. Patient can go home tomorrow after this anterior and posterior approach. So spinal surgery is not always so much invasive. It can be really minimally invasive nowadays. Principles of spinal surgery. We should, when we have some neurological symptoms, we should decompress neurological structures in all kind of manners. We are performing fusion. Why? It's arthrodesis basically. Why? Because there is some kind of symptomatology that should be treated by fusion, especially in trauma cases. And to promote fusion, we have to make vertebral dynamic segment still for some quite of time. So we need instrumentation. We put the screws to have that motion segment completely still until the fusion is achieved. And you have disc arthroplasty, but for disc arthroplasty there is really not so wide indication. The patient must be perfect candidate so you can make disc arthroplasties. So if you have ever heard of spine transplant, I would like to know. And that's it for my first talk. Please, we can go to spinal trauma. Is there any questions about spinal surgery, basically? If there is, I would like to hear. I'm here to simplify the spinal surgery, because it's not so demanding. It's not so hard, but it's just something a little bit different than your experience so far. If not, let's go. Spinal trauma. How many of present participants have to deal with spinal trauma patients, not in surgery, in ER? How many of you have to deal with spinal trauma? Have you ever seen spinal trauma in your office? Yes, mostly of you. Most of you, yeah? Okay. Again, same disclosures. Spinal trauma is 3 to 6% of all skeletal injuries. It's complex diagnostic area. It has a bimodal distribution. Bimodal distribution means young people from high energy trauma and older people with low energy trauma. It's a potential devastating incident for the rest of the life of the patient. About just 1/3 of spinal traumas should be treated surgically. And special entity is spinal cord injury, which makes damage to the spinal cord and which can make temporary or permanent changes. There are some regional differences in spinal trauma, in spine at all. We have cervical and thoracic spine, where the spinal cord is in the spinal canal, and cervical and lumbar spine are pretty mobile, and two very important in terms of spinal trauma, two very important regions, cervicothoracic and thoracolumbar junction, where is load shift. So you have to consider that always fractures around the cervicothoracic and thoracolumbar junction must be diagnosed completely. When we are talking upper cervical spine injuries, it's a complete different entity. They are not so usual. It means from C0 occipital condyles. And we should consider, is it stable or not? Mostly of them are stable. When you are considering first cervical vertebra stability, you must determine integrity of the transverse ligament. When you have odontoid fracture, dense fracture, you have 3 types by Anderson D'Alonso. You know about them? Which type of Anderson D'Alonso dense fracture should be treated surgically? Only one. Which one? Which one type? Second. Why? It's the fracture of the base of the odontoid process, and because ligament is intact, it's a high potential for what? For? Say it aloud. This is not a lecture, and I will not give you some marks after this. Pseudoarthrosis, very painful pseudoarthrosis, and you can treat type 2. You can treat in some kind of minimal invasive manner with only one screw, but if it's fresh, if it's painful pseudoarthrosis, you should go posteriorly and to fix C1, C2, or even to occiput, and then you are reducing motion of the neck. And there is traumatic spondylolisthesis of C2. Have you ever heard about hangman fracture? It's C2, traumatic spondylolisthesis. Then we are going to more severe injuries, because more severe they are more often, and they are more devastating usually. Subaxial cervical spines from C3 to C7. Also bimodal distribution, injury mechanism, motor vehicle accidents, fall from height, dive or fall into shallow water, and sport injuries. When you have patient with some finding of neck problem, you must ask him if he's awake about injury mechanism and all associated disorders or injuries. You will always have palpation tenderness on clinical examination. You have muscular tension, deformity, hematoma, or hypermobility. Be aware of hypermobility. Do you have the Canadian C-spine rule? When you should apply some kind of collar, rigid, soft, it doesn't matter, but apply some collar when the Canadian C-spine rule is suggestive. Canadian C-spine rule. Then, it's most important. Mostly of you are residents, as I heard. So, in ER, you'll see a patient. He's awake, probably based on his injury. He will need some kind of sedation, intubation. Record neurological status. Perform neurological exam. You have on the internet. You have free this form, American Spinal Injury Association. You can standard classification. Just put the X marks, what you have found. You don't have to know, is it Asia R or Asia E, but just put the marks. So the spinal surgeon who will treat the patient, if he sees the patient after the intubation, he's not able to determine neurological deficit. What's wrong with these pictures, with this image? This is the most cause of misdiagnosing. What's the wrong with this image? You must know that. If you work in any trauma center, you must know why this is wrong. Very, very, very wrong. No, doesn't have a color, okay, but it's not mandatory if he's not complaining about some pain. We are seeing like this X-rays almost every day. How many of vertebrae are in cervical spine? 7. Which one is this one? 2, 3, 4, 5, 6. You can see the lower end plate of 6 and the whole C7. I'll show you later how can it be. So there is a classification of AO, of subaxial cervical spine injuries, and then you have A type, B type, C type, and F type. A type is compression injuries. A0 is spinous process injury. It doesn't need any treatment. A1 is one end plate is broken, but A2 is split, also called pincer. A3 is incomplete burst, and A4 is complete burst. Basically and theoretically, all A type of fractures doesn't need surgical treatment, but mostly A4 and A3 are treated surgically. Why? Because of potential or pre-existing kyphosis, initial kyphosis, or potential kyphosis in the later stage of treatment course. B type means that fracture line is going from anterior to posterior columns. So B types must be treated surgically because they will develop also some kind of pseudoarthrosis, kyphosis, and so on. In C-type fractures, mostly associated with some neurological deficits. It's translation. When we are looking from the lateral, it's translation of the vertebral body on another one. You have translation, so it's C-type, always C-type. Always treated surgically. Sometimes you should go combined anterior, posterior, anterior, or posterior, anterior. And facet injuries. Facet injuries means fractures of the facet joints. There are 4 types of facet injuries. F1, FF2 can be treated. F1 can be treated for sure by conservative treatment. F2, they have potential for instability, but F3 and F4 have a high potential for instability and should be treated surgically, always. What's the treatment goal of subaxial trauma? Permanently stable and pain-free cervical spine. If you diagnose it early and proper, if you treat it early, patient can go home tomorrow, in most cases. You must avoid secondary neurological damage. If you are manipulating with the patient, if you do anything with the patient, just have in your mind that you must prevent any further damage to neurological structures. And you must facilitate of improvement of you must avoid facilitation of improvement already existing neurological deficit. All therapeutic measures should consider the best possible preservation of motion, so do not overtreat them to make rigid spine, and restoration of the spinal profile, because if you fix them in kyphotic position, they will feel pain on the posterior back of the posterior neck. So, how we make decision for surgical procedure? As I said, for A3 and A4 fracture, we should measure the angles. And when we are measuring the angles, we are measuring the delta, the difference between the measured angle and the normal value in this specific segment. So, and we have table, so we can say, okay, its delta is too much, we should operate on him. Instability criteria. Subluxation of a facet joint less than 15% overlap on lateral X-ray should be suggestive for surgery. Fracture of a facet joint more than 10 millimeters or 40% of the facet joint surface. Sagittal translation, as I said, translation more than 3.5 millimeter and more than 15 degrees delta. What's wrong with this picture? This guy ruined my Christmas evening last year. Again, it's another patient, it's not the same patient. What we had on CT scan. It seems everything right here. Yes or no? Yes. But he have pain. And he have some paresthesia in his right arm, in the fingers. You should go to the CT at least. Sometimes you should ask for an MRI in the middle of the night. But sometimes you should, if you are dealing with trauma, with spinal trauma. So, what kind of fracture is this one? What type? Is there a translation? So, it's C-type. Okay. So, one more very important thing. You should, as I said, you should note neurological status before any other intervention, because I tried to reduce it closed. It was impossible. I put the, for the Crutchfield traction, I put the Crutchfield traction, nothing happened. So I went to the OR, you can see the tubus, and I went to the OR, made a close reduction. But what's the problem with this? I don't know if I made any further neurological damage with this maneuver, okay? I had a lot of luck. In most cases you wouldn't, but you never know. I had a lot of luck, made a compactomy, anterior fixation, and that's it. Thoracolumbar fractures. The same strategy on thoracolumbar fractures, the same strategy is applied for types of fractures, but there is no facet joint fractures, A, B, and C. A should be treated conservatively in most cases, except A3 and 4. You can put braces, some kind of bandages, big bandages, and Javet brace, three-point brace, and they can go with that brace for 12 weeks. More than 70% of them will be okay. A3, if there is an initial kyphosis, that's why you must take upright X-ray, standing X-ray. You must measure that kyphosis. Or you can make, if you are not sure is it stable or unstable, you can make upright X-ray and laying down X-ray. You will see the difference. There is a big difference. If you are not a spinal surgeon, ask the spinal surgeon. I have a patient. I think that I have a problem. And at the end, for the last few slides, spinal cord injuries. It's an additional entity in spinal trauma. It's devastating, but in many cases treatable condition. It's a symmetric neurological deficit of the extremities with a circumferential sensory loss below the injury level. And they are mostly flaccid, with loss of reflexes accompanied with systemic hypotension. So be aware of spinal shock. Treat them early. There are some syndromes. I don't have time, unfortunately, to explain all the syndromes, but there is complete transversal myelopathy, spinal shock, central cord syndrome, Brown's-Sequard, conus medullary syndrome, and Cauda-Equina syndrome. In trauma, you will see the most usual spinal shock and central cord syndrome. And you should know them. You should know how to treat them. You should know how to identify them in your office. Why there is a spinal cord injury in trauma? Because it's a combination of retropulsion fracture fragments. And are they possible for minor trauma? And when? What do you think? There are a lot of elderly people outside, and they have pre-existing degenerative spinal conditions, advanced spinal conditions. They have narrowed spinal canal. Minor trauma can potentially cause the big damage. And then you should be quick. If they have any anticoagulant therapy, you should always ask about that, because they can develop in time of few hours. They can develop epidural hematoma with compression of spinal cord. Then you should go into the OR very quickly. As I said previously, Asia scale is really reproducible, usable, user-friendly. Just mark them with X's and everything will be fine. Diagnostic workup, as I said, X-ray, if it's feasible, make it upright, standing. Multi-slice scans with multiplanar reconstructions. Always ask your radiologist to upload to the system reconstructions, because they are looking at the reconstructions, but they are not uploading them usually. You must insist on that, because you can't make your decision based on just from the axial slices. And MRI, yes, we need MRI. In spinal trauma, we need MRI, because we need to see is there any ligamentous injury, compression of the soft tissues, some hematoma or edema in spinal cord. Treatment, NESIS protocol, high doses of glucocorticoids, they're abandoned. If they are not administered before you take over, don't use them. You don't have to. You should ask for the mean arterial pressure with your ICU unit between 85 and 90 through first week. It's really, really, really important. You should see if there is any kind of dislocation of facet joints. If there is any, you should modify your treatment plan. And when to make surgical reduction, decompression, and fixation. As soon as it's most safe for the patient's further medical condition. And there is, last two slides, special considerations. What do you think? What's in special considerations in spine? A little bit connected with basic science. What's AS? Say it aloud. Great, ankylosing spondylitis, and also called morbus Bechterew. And diffuse idiopathic skeletal hyperostosis. I'll give you my slides. You don't have to take my photo. You don't have to take photos. I'll give you slides. Okay. So, again, what's wrong with this picture? What's wrong with this X-ray image? We can't see the whole cervical spine, but patient is complaining about very, very strong neck pain. And when you see any sign of any condition like dish, morbus Forestier, or some ankylosing changes, ankylotic changes on the X-rays, ask for CT, because it can be like this. Patient is walking around ER in the hospital. He's walking to the X-ray, but he's complaining. He was misdiagnosed and came back tomorrow morning. Even neurosurgeon visited him on the initial visit and said, okay, you can go home. You are drunk and crazy. But he was not drunk and he was not crazy. He ended up very bad. So, take-home messages. Insist on true patient history, clinical assessment, and proper imaging. And you have classification systems. You have a lot of tools today not to be afraid of the spinal injury. Just follow these 2 bullets, and everything will be fine. You don't have to be spinal surgeon to save somebody because of spinal trauma. You just need to be aware of this, and that's it. Thank you very much.
Thank you, Dr. Chorluka. If there are any burning questions, you can ask him, Doctor, now, or we can save the discussion for later.
I'm completely open for questions. I'm looking for them.
Okay, then I
or
will...
you can approach me later.
Yes. Then I can give the give the chair to Panayotis Diaremes, our dear colleague from Germany, to give us a talk.
It works. Okay, very good. Welcome. Thank you very much. Thank you, Marco. I'm thanking also the organizing committees. Everything is perfect from the organization. My name is Panagiotis Diarmes. I'm the acting head of the spine unit in the University Clinic in Frankfurt. We are having every pathology treated together with our neurosurgical colleagues. And we will speak first about the cervical radiculopathy and myelopathy today. What we should know about it, it is so that its spine is always complex. That's something we can speak about 1 or 2 days if we want, and that's why we have to classify and we have to go step by step. First of all, the symptoms of a cervical radiculopathy are very versatile. You have patients who have only headaches or pain in the scapula or in the shoulder. Neck pain is the most common, and then you have the brachialgia, the pain in the arm. The most common roots that have a problem are the C6 with numbness on the thumb and the C7 with numbness in the third or middle finger. And you can also have weakness of the hand muscles. The patients speak about problems with overhead activities if they have a C7 problem, and they speak about difficulties with the grip strength if they have a C6 or a C7 problem. You are all familiar from anatomy with the dermatomes. Take into account that you have some pain regions that can be tricky. For example, pain in the scapula is most common symptom of a C6 herniation. All the muscles you have to know for your neurologic examination is something that you have to do every day or every time you have the opportunity to do it. Try and do it thoroughly. Don't do a very, very quick examination. Take your time with the patients and speak with them. C5, the first thing to do is abduct the shoulder and see if there is active abduction. You have the biceps reflex there, and you have the lateral, the lateral upper arm. C6, you have the biceps itself and also the hand dorsiflexion, and you have the brachyradial reflex. And C7, you have the intrinsic muscles of the hand and also the triceps. You have a C3 or a C4 radiculopathy if the patient has some headaches or problems with pain in the face or in the eye. You have a C5 radiculopathy if the pain and the numbness are in the superior shoulder and the lateral upper arm. And the C6 is most common with paresthesias of the thumb. C7 and C8 are also very common. If you don't know all these, what's normal? Take a table like this, make it a pocket card, and try to see what the patient has. Is there any motor dysfunction? Is there any numbness? You have to be thorough with your examination there. You have to take the time and examine the patient. Some of the clinical examinations that are very important for the cervical radiculopathy are Spurling's test. That's done so that you put the head in reclination and in torsion to the one side, and then you press down. What you do is that you make a foramen occlusion there, and if there is a herniation or an osteophyte there, patient speaks about irradiating pain in the dermatome, in C6 or in C7. Yeah. At my first residency years, I thought I have not learned that, and I thought, oh, I found a new test for herniation, but that existed a long time. I only didn't knew it. Most of the patients come with a lot of pain, and they come in your practice. So, oh, doctor, if I don't have the arm here, I cannot live. It's so painful. They have a herniation. That's let's say the laseg of the cervical spine. Yeah, you have the Valsalva maneuver. If the patient presses and the pain aggregates, that's also a sign of a herniation in the cervical spine. And finally, you have the Lermit sign. The Lermit sign is so that if you flex the cervical spine to the front, the patient calls about irradiating pain in both arms. You can also test it in that way. Don't force it. Pull the head to the front and then let the patient raise the arms up. And if there is an irradiating pain, not a neck pain, irradiating pain, you have a positive Lermit. You have an indirect nerve compression or a myelin compression there. Treatment options of the radiculopathy are most of the times non-operative. If the patient doesn't have any neurological deficits, any problems with his gait or other problems, in most of the times, 75% of the patients go well with medication, rehabilitation. If the patient doesn't get well, I have a very good experience with these selective nerve root blocks and facet blocks. You have to take care. You are not allowed to go in the foramen. Yeah, that's something that only the radiologist should do. You can do periradicular therapy. You can go to the bone and stay there. Yeah. Either from the side or from the back, where you feel more comfortable. Don't use more than 2 cc's of corticosteroids and of local anesthetics, because that's too much for the cervical spine. And if you use corticosteroids, you have to use special corticosteroids because they can cause a spasm of the vertebral artery and a hemiplegia. That's something for the more experienced. What are our options in the operative field? If you have persistent pain more than 3 months, progressive neurological symptoms and neurological deficit that doesn't become better, you have the option to operate. The gold standard is the anterior cervical discectomy and fusion. It has, in a single level, a pseudoarthrosis rate of 20%. That's why you have to see the patient factors and optimize them. And if you go to multi-level, the pseudoarthrosis rate is higher, and you have adjacent segment disease there. The other option that's more neurosurgical one, we don't become these patients in our clinic. That's something that all the neurosurgeons do in ambulatory basis, is the dorsal foraminotomy. This is an option. If you have a foraminal soft disc, you can go where the disc is, and right now it's more common to do it endoscopically because the spinal trauma in the muscles is less. And then you have the other option with cervical disc arthroplasty. It preserves the motion in the cervical segments and has equivalent results with ACDF, but it is something you have to do perfectly because you have a lot of heterotopic ossification if it is not perfect. The cervical myelopathy is also chameleon. That means you have to be suspicious. Don't let a patient that comes with leg pain and is 85 years old go away if he has both pain in the right arm and the right leg. It was first described as cervical chondromas, 1988, and since then we have many manifestations and many variations of it. That's so that the most common cause is degenerative cervical spondylosis, the osteophytes, the discs, and the degenerative spondylolisthesis cause narrowing of the spinal canal and of the foramina. And you have some patients that have congenital stenosis, and with a mild narrowing, they have big problems. You have the ossification of the posterior ligament, tumor, epidural abscesses, trauma, and cervical kyphosis can aggravate it. How does this happen? You have a direct cord compression there that's chronic. Most of the patients don't come and say, okay, I cannot move my arm. You see them in 1 month, in 6 months, in 12 months, and that deteriorates. And that's something you don't see in an acute situation. You have to be suspicious there. What happens is then that the arterial compression causes chronic ischemia, edema, and then venous congestion, and these repetitive neural and ischemic injury make this enhancement in the myelin and deteriorate the situation of the patient. We have many classifications. The most common right now is the modified Japanese Orthopedic Association scale. It has motor function of the upper, lower extremity, and sensory dysfunction of the upper extremity, and also bowel and sphincter dysfunction. If you have a mild myelopathy, you have 15 to 17 points, 12 to 14 as a moderate one, and 0 to 11 are a severe one. And then you have to do a thorough clinical examination. The most common is that the patient has a weakness that you don't detect. The patient comes in your practice and sits in a wheelchair or cannot stand enough. The problems you can see are the sensory ones. If there is a proprioception dysfunction, if you have decreased pain sensation, you can exercise there with the ASIA score, for example. Yeah, and one of the most common signs is the Hoffman sign. When you snap the distal phalanx of the middle finger, that causes a spontaneous flexion of all fingers. That's a sign of myelin compression, chronic myelin compression, and always see the reflexes. Sometimes the reflexes are different to one side, from one side to the other. That's why you have to be suspicious there. And I always, if a patient comes with cervical problems, I always examine also the toe and heel walk, and the Romberg test that are very indicative of a myelopathy. Conservative treatment options are good for mild cases, but we know that the natural history of myelopathy is so that it will be operated in the future. That's why we have to choose an operative strategy. Our goal is to reduce the myelin compression, restitute physiological roll lordosis, and deal with the segmental instability. And the ventral compression of the myelin is better addressed with a ventral approach. The most common is the cloud method. We have gone away from the iliac crest substitutes because they have a lot of multimorbidity on the iliac crest, and because the cervical spine heals so good in most of the times. If you do an ACDF, in this case, you can do it only in limited situations because you, most of the cases have big osteophytes that are not good accessed through the anterior discectomy. That's why you have to think about a corpectomy at this place and then do it so that you take away the myelin compression. If you're doing ventral plating, 2 fixing points are not enough. You have always to use a third one. Yeah, that's 2 fixing points are unstable. Anterior approach has the advantages that you do a direct decompression. You see the spine and you see how good you have decompressed afterwards. Always do a postoperative MRI in the cervical myelopathy patients. The reason is that after you do your decompression, you may miss something, or you may have problems dorsally. That means you have to do a combined approach. Dorsally, you have a lot of options for the decompression. The only problem you have is that you have a problem that comes in the anterior, and what you do is you create space posteriorly, which means that the myelin has to move posteriorly. The most common problem there is a C5 palsy after the operation. You can see that here you have more posterior compression of the myelin, and what you can do there, the neurosurgical colleagues do it more often, is do a complete laminectomy. That was a previous surgical strategy, and right now the open door laminoplasty is an option. But if you do a laminectomy, you may have instability problems, or also problems with a pseudo-meningocele. What is the best? There is nothing best. You have to cope with the patient. You have to adapt to the patient. You see this patient was decompressed ventrally from me, and then you see you have a good decompression, but you have here also an osteophyte from the back with this flava hypertrophy, and then you have to go to the back and take it also away to avoid this kinking.
We have to wrap it up.
Yep. Take-home message is that you always have to be suspicious. Surgical radiculopathy can be very versatile. Conservative treatment is state of the art. Only patients with neurological symptoms and therapy-resistant pain can be operated. And for the spondylotic myelopathy, have a thorough examination and always ask a neurological colleague. Thank you very much.
Very nice. It's a major theme, and it cannot be addressed in a couple of minutes. But yeah, unfortunately, we have to go now to the cities, and let's just do your best.
So it's also a vast theme. This spondylodiscitis is a chameleon. You have a lot of patients that are in the internal medicine with pain in the back or unclear CRP, and then the history is that it's not so new. An Egyptian mummy with tuberculosis spondylodiscitis was already treated 3,000 years before Christ. Hippocrates also, with his ladder, tried to treat it. And it is not only history. We have their also anatomical location, 50 to 60% are in the lumbar spine, 30 to 40% thoracic, and 10% cervical spine. The risk factors vary. You can have intravenous drug abuse, diabetes, geriatric patients, immunodeficiency, and malnutrition are the most common causes. The etiology of that, most of the cases are gram-positive bacteria. Staph aureus is almost in 40% of the cases, and then E. coli comes in 23% of the cases. in Europe right now, because of the immigration, we have more cases of tuberculous spondylodiscitis also. The most common way to become a spondylodiscitis is over the blood, and sometimes you have direct inoculation by open fractures. And if you have, for example, tuberculous spondylodiscitis, it can be percutaneous from the lung. The most common symptom is pain. It's nightly pain, which becomes worse with activity. That's why if you have a patient where you cannot explain why he has pain in the spine, do an MRI. Sometimes you will find the spondylodiscitis there. Neurologic symptoms are very rare, 10 to 20% of the times, and radiculopathy and myelopathy also. In late stages, you have a coronary or sagittal deformity. What do you have to do? Before you start with antibiotics, you have to find what kind of enemy you have there. Yeah? Take at least 2 or 3 vials of blood cultures. If you have the possibility, do a CT-guided FNA. It is good in some cases if you have geriatric patients, but the gold standard there is to become an intraoperative tissue sample, and always, if available, do an 16S PCR so that you are sure that you have the agent, the infectious agent. Yeah? It is essential for the whole therapy. Imaging, radiographs are good, but you have this end plate erosion, but the gold standard, of course, is the MRI. In the MRI, you ask for, in these cases, for tumor or osteochondrosis, that is the differential diagnosis there, and you have as findings paraspinal and epidural inflammation, disc and end plate enhancement with gadolinium, and also an hyperintensity of the disc and the end plate. Bone scan is only reserved for the cases where you cannot have an MRI, patients with a pacemaker, for example. And the treatment of the spondylodiscitis is, if you know the infectious agent, you can go non-operative. You have to treat 6 to 12 weeks and consider bracing. The operative way is one open biopsy alone, take as much as you can from tissue, and in the cases where it is needed, neurologic decompression, surgical debridement, and spinal stabilization. The conservative treatment has to be early, and it has to be with bed rest most of the times. And I don't know if you have patients that can stay in your hospital 12 to 30 weeks. I don't have any. And I'm thankful for that. The antibiotic therapy has to be at least 6 weeks, and you control the therapy via CRP monitoring. The success rates, if you do all this, are up to 90%, but you have 25% to 55% of patients that convert to operation because of the pain or because of the progression of the infection. You can start immediately with broad-spectrum antibiotics if you don't know the agent or till you know the agent. With the blood cultures, you have most of the times the results with resistogram in 2 days, so you don't have to go along with that. Yeah? And the duration of therapy is after an operation, intravenous antibiotics for 2 to 4 weeks. And if you have an uncomplicated discitis, you can stay without an operations, but abscesses have to be drained with a CT's guided drainage, for example. Change to oral antibiotics if the CRP has been the half, and if the patient is getting better. Operative therapy is, for my opinion, the gold standard there. If you have neurological deficits, if you have sepsis, and is an emergency if you have epidural empyema. If you have a big abscess there, you have to operate it and decompress it. And if you see a deterioration under the conservative therapy, you also have to consider operation. Instability signs are a segmental kyphosis here of more than 15 degrees, a vertebral body collapse of more than 50%, and a translation indicating instability more than 5 millimeters. The principles are local and radical debridement. You have to deliver also antibiotics locally and don't have any problems to use implants because through the stability, they have better healing rates, and the new titanium implants of the last 2 decades are safe for an infection, let's say. You see a patient with a normal spondylolischitis that was a staph aureus, and you see how much involvement you had here in the soft tissue. That's why you cannot see anything here. That's a standing X-ray. But if you see closely, you can still see something. If you go back, you see here you have approximately 25 degrees, and here you have, sorry, it's inverted, 45 degrees of kyphosis. That's unstable. And if you do it, you have to go along this patient. I said, okay, I will do 3 above, 3 below, and the problem was that I had a distal cut out, and I had to go more distally. Application of local antibiotics is very, very important. You reduce with it the biofilm, and you have osteoconductive properties. They can be combined with allografts, and you can combine the antibiotics. This is what now exists in the market, and you can use any of these. You have to know what properties you need. Yeah. And I will go a little further and a little faster for the spinal tuberculosis. It is also known as Pott's disease. You will know that is caused from Mycobacterium. Its incidence is increasing all over the world right now, and the reason is that we have more immunosuppressed patients, and we have biologicals in rheumatologic patients, and in also a lot of antibody therapies in oncology that can do more harm in these ways. The symptoms are similar to the normal spondylolischitis. What's more is that it's a chronic situation with malaise and nitrates and weight loss. You have most of the times a kyphotic deformity with neurological deficits up to 50% of the patients, and you have most of the times a mechanical compression of the cord. And if you do have such a thing, you have to go to surgery, and you have to decompress, you have to take the abscess out. You need special diagnostics for the tissue samples. That's what our tissue samples are as a standard, and you need for the therapy special HNT and ophthalmologic consult. The conservative treatment is an option if you don't have any deformity or spinal cord compression, and the operative treatment is most of the times bigger than the normal spondylolischitis. Take-home message here is that you have to assure the pathogen detection and a resistogram, and when necessary, operation is a safe option. Complex cases need interdisciplinary treatment and suggestion from an infectiologist. Thank you very much. Any questions? Okay.
Okay, think of the questions and we can proceed now to...
Again, let's welcome Dr. Vasilis Igoumenou for his next talk.
So, hello again. Now to the subject that's more familiar to me and I feel more comfortable to speak about. When we had the talk about the spinal fractures from Cerluca, Dr. Cerluca, actually he ended up his speech about AES and DISH. And he mentioned many things that will be helpful about my speech now. So, why do we separately examine patients with AES and DISH? Actually, if you're an orthopedic surgeon, you don't care if this patient has AES or DISH actually, because these patients' spines behave pretty much the same. The problem is that they have very rigid spines. It's maybe important for if we are internist or a rheumatologist or in basic science researcher or something like that to differentiate between these two entities. But these patients, when they come to our office and when they have a problem that is related with the spine and has to be treated, they're pretty much the same treated in terms of trauma. My speech actually is more about trauma. I have some slides about the balance, the sagittal balance. If you have time, we can discuss about it. And I will proceed with this picture. So this is pretty much typical. This is a patient that came to the emergency department. He fell from his bed and he sustained this kind of an injury. We were lucky to see that despite that we had this terrible X-ray, as we said earlier, that we had, it was pretty much obvious that we have here a fracture, and then we have to treat it, right? We're orthopedic surgeons, we have to treat, we have a fracture, we have to treat it. What do we do? Do we go directly to the surgery room? Do we do an MRI and then to the surgery room? Or maybe we can do nothing. Nothing is out of option because we have to treat this patient surgically. And why? I will explain to you later. We decided to go to the surgery room. We did a dorsal stabilization, navigated, and that was all. And I will explain now why we have to be a little bit aggressive, because these fractures are mainly type B and C fractures. We have to understand this because, and I will show you some slides later, you will take it as standard that this patient has an unstable injury. That means that doing the conservative treatment is most probably nowadays in somehow kind of malpractice, would say. These patients are mainly men, and they're very predominant to falling and to sustaining fractures, okay? Guidelines. Actually, the only guidelines that exist in the literature are from the German Society for Orthopedics and Trauma. And what they say is that the non-operative treatment is not recommended in these patients. We mainly have to do, as said, with mainly B and C type of fractures. And we have to do a CT for all these patients, and MRI, we'll speak about this later. And then we have some suggestions. These are not like strict guidelines, but we have some suggestions about the treatment. Anterior, posterior, 360, we can do several things. And they suggest that MIS may be more profitable for these patients. So we have this cataract here, this algorithm. I hate algorithms, but we will make it more understandable in a while. Why do these, how do these patients sustain a fracture? It's mostly hyperextensions and not, it's low energy injuries. And we have to also remember that in these patients, most of the times, the whole spine may be affected. So if you see a lesion there, an injury, maybe you should search also somewhere else for another concomitant injury. Neurology. We have very often neurological problems. How often? It's about one third of patients and 11 times higher than compared to the general trauma population. So you have an unstable injury that is also closely related to neurological damage. And be very cautious to the transfer, because literature says that about 15% of these patients develop a neurological deficit when they transferred. Now, CT and MRI. Several studies show that in these patients we have concomitant injuries in the epidural space, and in the remaining, actually we cannot say that these patients have any remaining ligaments like the posterior ligament complex, the PLC, as in a normal population it is consolidated, bonely consolidated, but we describe it in terms to understand as each other, the remaining ligaments that may exist, they're also most of the times they're injured. And we have cases of epidural trauma. So we're not obligated to do an MRI only if we see that the patient has neurological deficits and if we have an inconclusive CT, okay? First of all, CT is of primary, it's our primary concern, okay? If we, as I said, if we have neurological symptoms, then we do both. If not, we do a CT scan. If our CT scan is inconclusive, we may then proceed to an MRI. And, very important, whole spine CT and MRI, okay? CT is very, very important, and MRI if you're inconclusive. There's no discussion if we have positive, if we have neurological symptoms, we have to do both, and we have to treat them surgically. When do we go to the conservative treatment? Only when we are completely sure that the patient has no fracture, okay? It's like cases where we have to exclude that the patient has a tumor. It's a tumor until you disprove it. It's the same case here. If you have a patient with AS or this, and he's injured and he has pain, you have to absolutely disclose the case, the possibility that he has a fracture. And why is that? Now we come back to the first slides, because the bone, the spine in these patients behave actually as long bones. So, are you gonna leave a femoral fracture untreated? No. Are you gonna leave a fracture like this untreated? The answer again is no. They have, the spine in these patients do not heal, and we have long lever arms that act. So any kind of like a collar, cervical collar, or a TLSO, like a splint or something like that, will not act appropriately in these patients. How all these treatments are nowadays a little bit abandoned, and the non-operative treatment actually is only in the second line and only for these patients that are completely, if your anesthesiologists say, okay, if we go in surgery, in theater, and we do the surgery, then the patient might die, will most probably die, then okay, we can avoid surgery. In other cases, we have to take the responsibility and perform surgery. Of course, it's not always very happy. This patient, for example, came to the ER with a minor trauma. He presented plegic. We did a surgery. He died 2 weeks later in the ICU, okay? There have many concomitant. It's like treating a patient with trochanteric fracture, but they're a little bit more risky. How much risky? You have a 36% 90-day mortality in the AS group in comparison to the osteoporosis group, and you have also major complications, but still, these patients have the surgical treatment in these patients seem nevertheless to have better results as the conservative treatment, okay? We have to keep in mind that we have to have a very close communication with the anesthesiologist, because intubation may be tricky, and also positioning, because these patients are very stiff, they have rigid spines, and when you turn them on the table, you have to be very, very careful to not make another injury. These photos are not mine, are from papers, from the literature. Remember the whole spine CT or MRI, and the secondary neurological deterioration, okay? And these patients have normally a sagittal imbalance. Do not do any correction of the sagittal imbalance during the surgery. Do not think, okay, I have the patient on my table, I could maybe do a slight correction of the imbalance. No, just fix the fracture, okay? There's a discussion about minimal invasive cemented screws. It seems that with minimal invasive surgery, we preserve muscle tissue, so it could be a good alternative. And now I have some patients of mine. These patients, for example, you may do a nice sagittal alignment analysis, but you just remain with fracture. This patient, for example, an 85-year-old lady, you don't see actually, most probably I won't see a fracture line here. That's why we have to do a CT scan. In the CT scan, we see the fracture line there that goes somehow down in this line. Then we do an MRI. In the MRI, you can see, actually, I would always recommend the STIR and the T1. The STIR sequence is very, very helpful. You see now how the actually it's chance fractures, it's chance injuries. They go back to the line. In your T2 sequence, it is, you see the fracture line there, but to have a very nice confirmation, trust the STIR sequence, and we did an MIS spinal fixation, dorsal fixation, not navigated. This is another patient. She presented in the summer. She had dementia. She fell. Actually, she was found on the floor. We did these X-rays. Again, you have very bad conditions also many times in the ER. You don't do much pressure, no panos, or if we see here something, okay, I will now say that here we have a fracture, but to be honest, for the first look, I didn't realize that this patient had a fracture. Of course, we said we have to do a CT. The CT revealed this line there, and the MRI as well. These are coronal images. Again, we have to perform, as I said, whole spine MRI or CT. That's depending on our abilities. And on the STIR sequence, we see the fracture line going there, and also expanding a little bit on the side. This was not MIS, this was an open fixation. And actually, this is the take-home message that I would like to give you for the fractures is do always a CT, complete CT scan, and behave, and non-conservative treatment is actually is out of the table for these patients. That's what I would like to say to you. Now, I don't know, we have 3 minutes, I see here. Maybe it will be a night pass for your speech later about imbalance and sagittal balance. I will say only some things. What's sagittal balance actually? Sagittal balance is how we stay on the sagittal alignment. And why is this very important? Because we have actually to maintain this horizontal visual axis. And these patients, as you see, you have a tendency to be more kyphotic like that, and they then have to compensate with hip extension and knee flexion to remain a horizontal gaze. Okay, that's actually the whole thing that we have to show there. This is the spinal parameters. No, I will leave it for you. These are the spinal parameters. Actually, it's very complicated. I can understand that, but for these patients, it's very important to actually this PI here is the index that shows us how the pelvis is staying, is in room, in space, in relation to the hips here, and it's a parameter that's very static and stable for all of us. Okay, we're born with this. We're born actually like that. And it's the sum of the inclination of sacrum, okay, on the horizontal plane, and in terms of this pelvic tilt here, pelvic tilt actually means if the pelvis is underverted or retroverted, okay? If pelvis goes underverted or retroverted, okay? But you will. So these patients have a main problem. As I said here, they have a problem with their balance. This is not of my patient, it's from literature, but they can present like that, or like that. And we have a balance problem, we have an alignment problem. We have first to find where is the alignment problematic. Is it on the spine, or the cervical spine, thoracolumbar, lumbar? Most commonly, these patients have a problem in the thoracolumbar spine. Then when we find the problem, we have many ways to find how we will correct them. the best analysis that is nowadays applicable is with SurgiMap. You can do a very nice analysis of your correction, and you can see how many osteotomies you have to perform in these patients. How we correct them? We have actually these our main weapons in our armor is the PSO and the SPO. PSO stands for pedicle subtraction osteotomy, and SPO is the Smith-Peterson osteotomy, in the German terminology Zilke, and the closing opening wedge osteotomy. What do we do there? Why is this going forward? The PSO can give us a very good correction, about 40 degrees, mostly. Okay, you're very lucky if you get 40 degrees, but we can say 25 to 40 degrees. And it's a closing wedge osteotomy. The other osteotomy is an opening wedge osteotomy. It gives us smaller degrees, but we can perform it in multiple levels. And then we have the cervical spine. There things get more tricky. You have to refer the patient to a clinic, to a department that does this more often, because these kind of osteotomies are related to a big loss, blood loss, etc., etc. And yeah, we have a lot of complications, but on the bright side, these people get very well after such an operation, and their quality of life is pretty much much better after the surgery. So, thank you very much, guys. If you have any questions.
And now let's welcome our Dr. Panayotis Diaremes again for the adolescent idiopathic scoliosis.
So, let's go to a more demanding population. It's not so multimorbid, but you have to take care of them as of your own. Yeah, children with idiopathic scoliosis. What we will speak about is how as the spine grows over the time. Oh, sorry. How the spine grows over the time and what is idiopathic scoliosis, and then go further with classification and the treatment options, conservative and operative. The growth stages of a child can be broken down to 2 to 5 years old. The spine becomes 40% of its spine length, approximately 2 centimeters per year. 5 to 11 years old, you have a deceleration, and there you become approximately 20% of your spine length with 1 centimeter of year. That's not the high, it's the spine length only, yeah? And from the 11th year, you have this peak high velocity where you become once more 40% of your final spine length. How can you assess it? How can you know where it comes? Every child is not the same. Every child is different. You have many tools for that. The most common is the RISER, and most recently, in the last 10 years, the Sanders classification. All the others are too complex to do it in your office. You have to wait from the radiologist to know something. The RISER sign is quite simple. If you have no ossifications, it is 0. If you have 25%, it is 1, and so it goes on. 2 is 50, 3 is 75, 4 is 100% of the apophysis, and if it consolidates, you have a RISER 5. And the Sanders classifications came approximately 14 years ago, and it revolutionized the spine treatment, the treatment of scoliosis, because it did a correlation between the classification and the treatment. And it is so that we know Sanders 3 are the children that have this acceleration phase, and that's where the tridentine cartilage of the hip goes away, and then you have the Sanders 4, and here is this peak high velocity is the point where the children have the most of their growth. And then here starts to be the evaluation of Reeser. In the girls, you have here the first period. And as you see, that's what Sanders did. It's so what's the possibility that the children have to be operated if they have a curve of 30, 40 degrees. And, the definition of the scoliosis is not so that we have only a frontal plane problem. We have a three-dimensional problem. That means we have a torsion and a rotation in every vertebra, and that results in a frontal and sagittal plane deformity. And we will see later in the X-rays why it is so and what we have to consider if we operate or if we treat with corset. The epidemiology is simple. It is a very common disease, and it is so that at 16 years old, almost 2 to 4% have more than 10 degrees, and 0.5% have more than 20 degrees. That means they have to be treated. And it is more common in the girls' population, and it is also most common that girls have to be operated for that. How do you assess or how a patient presents? It is so that you have some of the times a trunk shift. If the spine is not more in balance, you see that the C7 plumb line goes to the right and not at the sacrum. You have an asymmetry of the waist triangles. You have an asymmetry of the shoulders with a shoulder imbalance. And the most easy thing for you to do in every setting, if you do school screening or if you see a child, my cousin told me, you have to see my daughter, does she have scoliosis? The most common thing to do is let the children bend over. First, do it so that you level the pelvis and then let them bend over so that you have this rib hump or the lumbar bulge. And you cannot know how severe the scoliosis is there. I had children that had a very, very mild lumbar bulge and they had 40 degrees of scoliosis. That's why you have to do an X-ray, and you have to do a standing whole spine X-ray. If you have access to EOS, do it. If you don't have a normal X-ray, in one film will be good. And then you have to calculate the Cobb angle. How you do it? First of all, you find your apical vertebra, that's the most rotated vertebra in the curve, and then you go up and down and find the end vertebra. The end vertebra always show you to the curve. I mean, this one goes away from the angle, and they are, in most of the cases, not rotated. The neutral vertebra is an end vertebra that is between two curves. And if you have all these vertebrae, you can calculate what the Cobb angle is. After that, you have to see if it's a major or a minor curve. Major curve is the one with the more degrees, first of all, and then if you decide and opt out for an operation, you can do bending. I don't do bending for children that are at 20 degrees, that's too much radiation, and I don't become any information that I need. Only if they decide for an operation, then we do the bendings. And if you have some atypical curves, for example, a left thoracic, or if you see something that you don't like, if the child has pain, that's uncommon for scoliosis, then you have to do an MRI to see if you have a tethered cord, an interspinal lipoma, and if you operate, you have to do a whole spine MRI to see if you have an Arnold-Chiari malformation. The imaging is the Cobb angle, first of all, and here you can see this Nash and Moe rotation classification, and here there is a 3 and 4. How do you classify scoliosis? So idiopathic is something that we'll know has no cause, no known cause for us, yeah? either if it's idiopathic or if it is something else, you first classify with the age. You have an infantile scoliosis if it is 0 to 3 years, sorry for the German language there. You have juvenile scoliosis, 4 to 10 years old, and you have an adolescent scoliosis if you are more than 10 years old, and that's 90% of your patients. But all scoliosis patients that are below the age of 10 are early onset patients. And then after them, you have secondary scoliosis, neuromuscular syndromal. We'll see some X-rays after that. And you have congenital patients. They come at the age of 0 to 10 to 5 years most of the times in the scoliosis office. And you have functional scoliosis. That's the most common scoliosis by children with leg length discrepancy. And you have the infantile scoliosis, that's a functional scoliosis that most of the times goes away. Congenital scoliosis, you have here these segmentation and formation failures. In the CT, it is so most of the cases have to be operated, not all of them. Secondary scoliosis can be neuromuscular, of CP children with cerebral paralysis are the most common there, and they can have an S form or a C form. And finally, Marfan and syndromal scoliosis can deteriorate very, very rapidly. This case was 45 degrees, as I said, for the first time. Until we went to surgery, we had 110 degrees. The idiopathic scoliosis has no known etiology. There is a familial predisposition, and we classify with Lenke. As I mentioned before, you have to find your main curve and then find the minor curves. And if you have to operate, you can do bendings. Then you can define if the minor curves are also structural. That's where you need the Lenke. You don't need it if the child won't be operated. You have the curve progression with the Sanders. That's what I spoke before. You see, what he did is that he classified the children with the Sanders classifications 1 to 8. 8 is mature, 1 is very immature, and then he saw that the children that had 20 degrees with a stage 1 Sanders had to be operated in 85% of the cases, and the children with 20 degrees with a mature skeleton, they don't have to be operated. And that's why we have to treat the children. Most of the cases, we only need conservative therapy. In some cases, we have to operate. Why? We don't need to operate the spine to be straight. We need to operate a spine so that the thoracic cavity has more place and more volume, so that they don't become any problems with the respiratory function, so they don't become a corpulmonale. And this publication showed that the children with scoliosis over 40, 50 degrees died earlier, 5 to 10 years earlier. That's the reason to operate. The SIM for the treatment is so that we have these therapy algorithms. If you have a child over 10 years old and has substantial remaining growth, you go to a growth-friendly surgery if they have approximately 50 degrees. If they're below 50 degrees, you do a full brace. And if they're below 25 degrees, you can do a night brace. They have to wear the brace most of the time. The goal there is that you stop deformity progression, and you have to detect a deterioration. That's why the children have to be seen clinically at least every 6 months and radiologically once a year or every 6 months. The Katarina Schroth therapy is a very good one, and if you have access to it, you should consider it. Custom-made brace, we use the Chenot. There are many braces there, and you see how the compliance goes. If you have a child that wears the brace more than 13 hours a day, you have a very good result there. 90% of the children won't be operated. that's how a brace corrects it. You have always to see that you don't have an overcorrection as here. You have 10 degrees overcorrection. The children are very flexible. That's why you have to control the corset therapy. If the right indication is there, if the child is compliant, and if you have more than 40% correction, you have a permanent prevention or correction. And then if not, you have to consider surgery. That means you have to speak with the family. You always treat the family, not the child only. You have to speak about the deformity progression to stop it. You have to try to correct it. That's not always possible. And you have to maintain the spinal balance, as Dr. Igoumenou said, in all 3 planes. And prevent surgical complications. That's not so hard, but that's something you have to do by children. You have always to use neuromonitoring. You have to operate according to the Lenki classification, and stop any revision if possible. The deformity correction has to be with respect of the coronal plane. That means you have to choose your weapons. You have to choose what you use for the patient, and you have to plan. A former consultant of mine had said, an unplanned surgery is a planned catastrophe. So plan these patients. That's so the lowest instrumented vertebra has to be a good one. This publication showed that if you go to the touch vertebra, that's the first vertebra from the sacral line, you have a very good result, also radiographic, also in the complication rates. And the coronal plane is so important in these patients because if you are imbalanced, you have problems with instrumentation. They are not good anymore. And that's what you can do. I have no more time, sadly. So you can go with growing rods if the children have many growing potential. You can go with VBT in some cases, and you have to be very careful there. And you can see the groin rods have all been replaced from the magic rods. These are rods that you can use to distract the spine and have a final fusion if the child is grown up. And you can see you can have good results there. The VBT, you have to do it right. That's too short. And you have the problem with the rod with the breakage there. That's a new, let's say, principle for VBT where you use double row. You have a better correction, but you have the problem in the coronal plane that they are becoming more kyphotic. And the gold standard is fusion, and it has very good results. You can see here this child with almost 70 degrees and almost perfect correction there. Take-home message is that you always have to do a thorough examination. The Adams test is the most simple test to do. Start early with brace therapy and address these children to a deformity surgeon. That's not something you should experiment. Thank you very much. Do you have any questions?
Now the next speaker is Dr. Vasilis Igoumenou for the spondylolisthesis, and also Professor Stoica has asked me to inform you that Professor Mineiro will come in the next, between the talks, to say some info about the EBOT exam. Sorry about that. Sorry about that. Still, Dr. DRMS with adult spinal deformity. I skipped one, sorry. I'm not spinal surgeon, I'm hip and knee surgeon.
So,
very intentional.
You heard already from Dr. Igoumenou that we have always older patients And that's something that you will find in your practice also. The population grows, and what we know is that that has an immense impact in these patients. As the patients grow, as more spine surgeons they become, yeah, and the spine surgeons are eager to operate, or the situations are there to operate, and that sometimes doesn't go well. And then you have deformities in the coronal plane or in the sagittal plane. And not only this, you have osteoporosis, you have many problems there that deteriorate the health of the patients. And this recent study showed that the patients with adult spinal deformity are so bad with their conditions that they can be compared with patients who have pancreatic cancer or who have major cardiovascular problems. That's why you have to consider an operation there, or a treatment at least. The etiology can be osteoporosis and idiopathic scoliosis that has not been treated or has been treated, and iatrogenic instability. You will see in your further career that not everyone stabilizes the spine. Sometimes it's not so bad, but you saw already this gooseneck deformity that results from extensive osseous decompression. The degenerative disc disease gives it all, and then you have a patient that's imbalanced. As Dr. Igoumenou showed, you have patients with different types of spine types, let's say, and some have a lot of possibilities to compensate it. So that's here, these types, and some don't. These types don't. They are decompensating very, very rapidly. And in order to classify it, you have to know what problems there are there. You first start with a coronal imbalance, and then you have a thoracic-only deformity. If the lumbar curve is below 30 degrees, you have a thoracolumbar deformity, or a lumbar-only deformity according to that, and you don't have any deformity in the coronal plane, but have problems in the sagittal plane. I don't have the publication right now there, but the revolution, let's say, in spine surgery was the one publication for the Dr. Rottenflew, where he showed he had two groups of patients, and he did retrospectively evaluate what the complications were. And he had two groups. One group was balanced, had a PI minus LL below 10 degrees, and the other group was PI minus LL above 10 degrees. And what he found was that the group with PI minus LL below 10 degrees had a complication rate for long spine constructs of approximately 20 to 25%, but the group with the discrepancy there had a complication rate of 85%. That's why you have to take in account spinal balance. What symptoms does the patient have? They have all the symptoms that a spine patient have. Low back pain, mechanical pain, neurogenic claudication are very common, and most of the times also radicular pain. These all the situations coexist in these patients, and you have to see what's the real problem. You have to take a whole spine radiograph, and with the hips included, as you will hear from Dr. Chluka as next. Most of the times they're not there. And then you can calculate the C7 plumb line and the pelvic incidence and circular slope. And then you can see, is this a balanced spine or not? If you have instability, you have to address it also. You can do this X-rays in function, in an inclination or reclination, and the instability can be in the sagittal plane as a spondylolisthesis, or can be in the coronal plane with a degenerative scoliosis. what you see here is this vacuum. That means that this patient had a CT in the lying down, and as Dr. Chorluka said, that's a lying down position, and you see that goes away, and as soon as it stands up, she has more than 30 degrees of scoliosis, or 40 degrees, and she has so much pain there. You have to correct it. You have you can do a CT scan if you have the possibility. You can do a myelography. You need an MRI for these patients because you have to see if such a condition coexists if you operate, and you have to do an osteoporotic status. If it is a DEXA or if it is a QCT, you have to do it because these patients are very multimorbid, and if you go there and put screws in an osteoporotic bone, the most probable consequence will be you have to operate once more. You can use new technologies for low-dose exams and whole spine and leg X-rays if you have access to them. They're very helpful for the planning of the operation. And you can consider non-operative treatment if the patient cannot be operated, or if the curves coronal are under 30 degrees, you can try a corset therapy, but that's not the solution in these patients. You have to optimize these patients. That means if you have the decision to operate, you don't have to do it tomorrow. You have to plan this patient. Curve above 50 degrees, sagittal imbalance and curve progression are reasons to operate. You have to see if these patients are operable, and then you have to choose your technique. If you go posterior only to correct the curve, or if you do anterior, posterior, and if the patient can opt out for an anterior-posterior procedure. And treatment goals are to restore the spinal balance in these patients, relieve pain, and obtain a solid fusion. That's something that you can do in a 40-year-old patient without any big consequences. If the patient is 85, that's not so simple. How do you correct? You select where to start and where to stop. You extend this fusion to the L5 only if the L5-S1 has no pathology. That's very, very rare in these patients. And you have to extend to the sacrum or to ilium if there is any pathology to L5-S1. The advantages to the sacrum is that you have increased stability of a long fusion construct. The disadvantages is that you have a high risk of pseudoarthrosis. That's why if your construct goes to the thoracic spine, in most of the cases you go to the ilium, and then you have to see if you augment this construct. If you do cemented screws, I always do in this patient augment the last vertebra to the thoracic spine to don't have any problems with failure of the osteosynthesis. The problems is, of course, that you can have a pulmonary embolism from the cement. And as Dr. Igoumenou said, you have many options to treat. You can do a Ponte or a Smith-Peterson or a normal, that's a Schwab 3, PSO, or if you have a stiff spine and you don't have any possibility, you can go further and do a vertebral column resection. That's not an option for very old patients. Complications reported 14%, I will say more than that, 20 to 30% are the complications in this population, and you can have everything. Dural tears, it's something that can happen. Infection is devastating by these patients. And neurological deficits, if you do in a PSO, can be up to 18%. That's why you have to do neuromonitoring there. And the most important thing there is plan. That means you have to anticipate the complications, and you have to see which of these complications are something that you can modify and which not. You can move the surgery 6 months later if the patient can lose some weight. You can make the nutritional status better. You can make the bone health better. In USA, they give these patients teriparatide 6 months and then operate them, for example. You can help the patients with medication for the mental health and prepare them for such a surgery. And then you can do a successful surgery where you address both the coronal and the sagittal plane with a PSO here, for example. Thank you very much. Any questions?
Do you use anterior approaches in treating, LLF and ALIF or OLIF for treating adult spinal deformities? Because there are also powerful tools for correction.
The most common problem with patients that are 80 or 85 is that they are already operated 1 or 2 times in front. Then I avoid it. You can do it, but yeah. If not, the new instruments with minimal invasive, this XA-LIF, are perfect to do it. You have an operating time of 1 hour for the XA-LIF, and then it's good. Yeah, me also, yeah. Then, yeah.
So, about spondylolisthesis. I think that most of orthopedic surgeons, when they see a patient with spondylolisthesis, either they will be afraid of it and they will see like this slip and they will be like, oh my God, you have a spondylolisthesis, you have to be as soon as possible treated, or they will just ignore the patient and they will say, okay, yeah, it's very common what you have, we don't have to do something. Well, the truth lies somewhere in between. I probably understand that, well, I'm Greek from origin, so for me it was not much a problem, but as I start speaking with foreign colleagues, I think that they have also a problem between spondylolisthesis and spondylolysis. What's the problem? And I will explain. Spondylolisthesis actually means that the vertebra is slipping, okay? And it's actually either anderolisthesis or retrolisthesis, slipping backwards or forwards. I think this classification is one of the best classifications because you can memorize it within 3 seconds and you know everything, and I believe all of you have seen it somewhere and you know it. 1, 2, 3, 4, 5, measured in classification, up to 25%, up to 50%, between 50 and 75, and if the spine, if the vertebra is slipping completely forwards, it's then spondyloptosis. That means that the vertebra is falling over. A more characterizing classification is the Wiltshire classification. We will talk about today isthmic and degenerative spondylolisthesis. Okay, when you have a traumatic or neoplastic, traumatic is already covered by Stipe, and it's a completely other situation. Dysplastic also belongs here to the isthmic one, so it's actually a cross. It's a cross pathology between dysplastic and isthmic. The difference is that dysplastic is more. It tends to progress and get worse with time. It's actually that here. What is pars? Actually, many of us had a problem at the beginning to understand where is pars. Where is this pars? What does pars mean? Pars is this here anatomic region between the 2 facet joints of the vertebra. And here then we have a lysis. This is the breakdown. And it's either a stress fracture, as it was this morning described by Marco. Either we have a stress fracture, it can be elongated, this is more to be born with. Acute fracture, this belongs to another situation, and then we have the degenerative. Spondylolysis now, it's the lysis, this here word means that the bone is, we have a breakdown. if a patient has spondylolysis, does not mean to have that he will develop spondylolisthesis. Again, if a patient has spondylolisthesis, does not mean that he has absolutely spondylolysis. Okay? We have to differentiate these things. Spondylolysis, it's typically seen to patients, to young patients, young athletes, and mainly athletes that are in gymnasts, and they have a repeated hyperextension. And these hyperextensions puts too much stress on the pars, and this leads to a stress fracture. 15% of these patients may progress to spondylolisthesis. Okay, so not all patients, of course, not all patients we have spondylolisthesis. The larger the slip, the more likely to progress. This plastic, as said, will tend to progress more rapidly. Now, the radiologic. Another thing that someone, the second thing that someone knows about spondylolisthesis, apart from measuring, is the Scotty dog sign. Okay, you will try to find it. Okay, that's here. That's in the oblique X-rays. Where is the dog? I will help you to find the dog. That's the dog. Okay, and that's the collar here. Don't get upset, don't get obsessed with this sign. You will see it most probably here, okay? But again, we have more modern exams today. We have the CT. You can see it very nicely in the CT scan, okay? And here again in the CT scan, this is a patient. I will talk about this patient a little bit later. Symptoms, any kind of symptoms a spine patient may have. Pain, neurologic pain, leg pain. Here, we can stay here. You may see hamstring tightness and radicular pain, the L5 nerve root, okay? Not the S1, most commonly the L5, because the root is strangled between the foramen. Then again is described the listhetic crisis and extremely rare cardiac vena. I haven't seen that yet in patients with spondylolisthesis. I don't know if you, Panos, or Stipe have seen a patient with cardiac vena, but I have to say it. In the exam, you don't have many things. I would only say that a palpable step, if you palpate the spine of the patient and you touch it, then you can see maybe a step off between the spinous process. And that's all. Maybe you have a straight leg rise test, maybe pain with single limb standing and lumbar extension. And these patients may walk may have a crouched gait when they walk because they try to compensate, because extension is very harmful, and they try to compensate this thing. The radiological examinations we do, apart from Megaden classification, we draw then these lines here, okay? And we see that, and we have this line, the slip angle. And the important information here is that if this angle is too high, higher than 45 degrees, these patients will mostly develop after surgery episodic arthrosis if we do the operation, and they're more unstable and they tend to progress in comparison to other patients. Treatment. Observation alone is very good for most of the patients because actually these patients don't have pain. So if you have a patient with these findings, no pain, you just do nothing, you just observe the patient. A good question if these patients have to return to contact sports. It seems that 3 months of sport absence will maybe do some good with patients who have relatively low, who don't present with so much pain. But these patients will actually come to you because they have something. They won't just come through your door and say, just examine me. They come to you because they have a problem. And mostly these patients have some pain, and this pain can be good treated if you do a physiotherapy, painkillers for 6 months, and this is very, very important. The hamstring stretching, the pelvic tilt, this is some exercises that physiotherapists may show the patients to do, and abdominal strengthening from the front. If after 6 months these patients don't improve, then you can have a TLSO, a brace. This seems to be a good solution, and we are now like almost 1 year after this patient has come to your office and he's still complaining about pain. This is about 10% of patients approximately that still have pain. Then we have a variety of methods, pars interregularis repair, where we do screws, and with 2 hooks we can grab the listhesis effect. Again, intralaminar here screws that they seem to fuse actually. We behave as we have a fracture, and we try to fuse. It's like a lag screw there. If we have then bigger, if we want to be a little bit more aggressive, we can do a posterior fusion, L5 to S1. It's mainly for measuring 1 and 2 patients. And for measuring 3, 4, and 5, we can do L4 to S1 fusion. It's not that good to fuse like a patient who's 17, 18 years old and do such kind of a fusion, but if we're out of other solutions, then it could be a solution, and you see here the correction. And of course, the other thing that we know about spondylolisthesis is reduction or no reduction. Should we reduce, or should we fuse it in situ? If we reduce, the patient may develop some kind of neurological deficit. Well, this is from October this month. This meta-analysis came and told us that the reduction may reduce the likelihood of pseudoarthrosis. And they didn't find a substantial difference between patient outcomes and reoperation rates and something like that. So there are some special indications for reduction, and I will tell a few things about them later. This is also another method. You can put some screws through the S1 to the L5, and you can have a tricortical or 4 cortical screws there with great stability. And in this classification from the spinal deformity study group, this came 10 years ago. There have been some studies about, and it's a very nice classification. It actually tells us we have 6 types of spondylolisthesis with or without lysis. The first 3 types here, we have a balance, and the other types, the first 4 types, excuse me, and these types here, we have an imbalance, either in the pelvis or in the spine, okay? Why is this important? Because for these here cases, reduction, as I said before, is maybe oh, the flowers. It's maybe a better solution to reduce here these patients. For these patients here, you may also apply just a fusion without being obsessive with reducing your defect. And again, here, what do we mean? So if we have this type of imbalance, either spine or spinopelvic, you should reconsider of reducing. In the other cases, it's acceptable if you just correct it in situ. And then that's another type of spondylolisthesis. We did a paper. It's like a most common after. This is after iatrogenic, after an operation, a surgery. Some patients develop a spondylolysis and spondylolisthesis, and this is actually, I just put it here because it seems that here also again sacral slope and pelvic incidence plays a role in this development of this complication, so to say. And I will have some minutes about degenerative spondylolisthesis. It's typically conservative. Refractory pain can be good, can be surgically managed. And keep in mind that high-grade ischemic slips may treat although safely, and that patients with higher slip angles tend to progress. So if we have a high slip, we have to be more cautious. What about degenerative? Degenerative is actually not absolutely with spondylolisthesis without absolutely lysis. It comes with time. It has degenerative, a degenerative aspect. It can be found most commonly between L4 and L5, and it's mostly grade 1 or grade 2. Patients who are occupational drivers or who have to sit a lot in their works tend to present this disease, and women are most commonly found to suffer from listhesis. Again, the spinal balance plays a role, and this is a newer, like 2015 it was brought, the CARDS, the Clinical and Radiological Degenerative Classification. Here it's more simple. I like this classification because it actually says us that we have A, B, C, and D. In the A type, you see that the disc is completely collapsed. There, you may also do only a decompression. Normally, a decompression is not suggested, cannot be suggested in these patients, but it's safe to do only decompression if the patient has leg pain and you don't have to put any screws or do any fusion. For these types, B and C, we see that we can do, there we have to do a fusion with or without a cage here in the vertebral. And here, for the last type where we have a kyphotic deformity, the intervertebral cage is well recommended. And at the end, I would like to give you some information about the NAS guidelines. This is the North American Association guidelines. We have to do an X-ray in standing position, MRI to assess stenosis, or myelography or CT myelography, and CT, not absolutely, but we can do it. So we have this patient here. This is a spondylolisthesis patient. This is now some tricks. So you see that patient here, okay? You can say that this patient may have a spondylolysis because the spinous process here, if we draw a line, is in accordance with the spinous process above and below. So most probably this patient, and that's why I did an CT to this patient, and we saw that we have, and I see that she had a lysis. Most probably the spinous process does not follow, so it's a nice way to maybe say that, okay, I have something here. About non-operative treatment, none of these treatments has been shown to be superior to another treatment. And about surgery, the North American Association tells us that direct decompression with fusion is better. Instrumentation is recommended only to improve fusion rates and not to improve clinical outcome. And the symptomatic low-grade olisthesis without stenosis, here you can have decompression alone, okay? That's important because there's a bit discussion between decompression with or without fusion, with or without screws. And about the all of these therapies here we have no sufficient evidence, okay? Then I had some cases, but I will skip them. I will only now is my time up. Let's see an interesting case made here. Oh, yeah. So that case, this patient, for example, he came to, the colleagues of mine did a decompression 2 years ago. You can see here the stenosis, and a decompression alone was done. After a year, he comes back, the pain was away, but the pain came back a year after. And we see that although the spinal canal is very well, decompressed, we have also, we have here a foraminal. This is a foraminal stenosis, and we had to perform a spinal fusion. And the slides, the cases go on. I will just finish now. I will tell only this. I showed you the X-ray before with a line that is in accordance. Here you see that the spinous process follows the vertebral body. So there most probably, although we have a very dreadful, not nice picture here with a spondylolisthesis, this patient still does not have a lysis there. It actually, you see that it follows, the spinous process is following the vertebral body. And I will rest my case for today because we are out of time. So, thank you very much. Any questions? Later.
Thank you very much, Vasily. We proceed with Dr. Schwinbacher with the degenerative spine disease and lumbar spine stenosis and disc herniation.
So, thank you. I have nothing to disclose. So, discogenic back pain is a common cause of axial low back pain without radicular symptoms caused by intervertebral disc degeneration. Numerous factors may initiate degenerative processes which most commonly affect the nucleus pulposus and ultimately influence the biomechanics of the whole spine. So the intervertebral disc is composed of mainly 3 layers: the annulus fibrosus with its outer and inner part, the central nucleus pulposus, and the terminal plates. The disc is vascular, made of fibrous tissue and cartilage. Microscopically, it is composed of scarce fibroblast-like cells located in the extracellular matrix, accounting for the most of the disc structure. Both cells and matrix are fundamental for normal function of the intervertebral disc. So many mechanical factors, depending on duration, severity, type, and position of load, affects the state of the intervertebral disc and thus the biological response to these factors. The border between the annulus of the intervertebral disc and the nucleus pulposus becomes more and more pronounced during the organism growth. The degenerative processes encompass the structural damage of the intervertebral disc and the changes in number and composition of cells. With aging and advancing degeneration, the nucleus is primarily affected. It becomes more fibrous and less elastic. So the main factor in the degeneration of the intervertebral disc is the loss of the proteoglycans, and which results in a fall of the osmotic pressure in the disc matrix. So and the consequence is the loss of water molecules, which affects the mechanical properties of the disc. As the generated intervertebral disc contain less water and have therefore inferior capabilities for sustaining pressure, the bulge, and loss of height. To classify the degenerative disc, we use the classification of Pfirman, which is a radiologist from Switzerland, which is mainly based on the disc height and on the intensity signal on the MRI, which grades from 1 to 5. So also osteochondrotic changes can be verified by the MRI with the Modich classification, which is nice to diagnose when visiting a patient with osteochondrotic changes. Treatment options includes always conservative and operative solutions like NSAIDs, or physical therapy, or lumbar discectomy with fusion by the operative way. So the lumbar spinal stenosis is a degenerative spinal condition characterized by the narrowing of the lumbar spinal canal due to a variety of bony or soft tissue structures. About the epidemiology, there is incidence is most common reason for lumbar spinal surgery in patients older than 65 years old. They're slightly more common in males than in females, 105 to 1, and the average age is, like I said, is 65. The anatomic location is in 91% at the L4, L5 level. And there are some risk factors also, like increased BMI, congenital spinal anomalies, or the Caucasian race. So about the mechanism, there is a narrowing of the lumbar spinal canal. It can be due to the bony structures, spondylolisthesis, soft tissue structures, herniated or bulging disc, or hypertrophy or buckling of the ligamentum flavum, or synovial facet sites. So in this MRI, we can see a central lumbar stenosis at the L3-4 level, while at the L3 higher level here, we have a wide spinal canal. Anatomically, the stenosis can be divided into the 3 main regions: central, lateral, and foraminal. And in this image, we can see here on the right side the central stenosis, in the middle the foraminal stenosis, on the left side the recessal stenosis. We use the Schiess's classification for the spinal stenosis, which is graded from grade A1 to grade D, from minor or no stenosis to the severe extreme stenosis. Surgical therapy is indicated when there is persistent pain for 3 to 6 months that has failed to improve with non-operative management, and progressive neurologic deficits like weakness or bowel, bladder, insufficiency, or claudication spinalis symptomatic. So disc herniation is defined as a local displacement of disc material beyond physiological limits. However, the morphology must be respected, and it must be divided into disc bulging, disc extrusion, and sequestered fragment. And the disc bulging disc is defined as a protrusion of the disc in which the largest diameter of the dislocated disc material in any direction is smaller than at the base. In the case of protrusion, the annulus fibrosus and the posterior longitudinal ligament are still intact, while the extrusion is defined as disc material leaking through the annulus fibrosus, the diameter of the leaked tissue always being greater than that at the base. The integrity of the posterior longitudinal ligament may be preserved, and there is still continuity between the excited disc and the disc which remains in the intervertebral space. So if there is a tear in the posterior longitudinal ligament, disc material can leak into the spinal canal, and if it loses the connection to the original disc, it is called a sequestered disc. The symptoms can be axial back pain, radicular pain, or cauda equina syndrome with 1 to 10%. And always for the physical exam, besides the inspection, a check for the neuro exam for radicular pain and radiculopathy. Therapy options are non-operative and surgical. Surgical laminotomy and discectomy, mostly microdiscectomy. So thanks.
Okay, before introducing our next speaker with the hip spine thematics, I would like to ask something to the audience, and this tree will probably kill me after that. Do you know why spinal surgeon every now and then does a total hip prosthesis?
Can I answer?
No.
It's an
For their
old-fashioned
mental
joke.
health, they want some good results.
That's an old-fashioned joke about spinal surgery, but I can't agree with you. But you had to say something during the spinal section, so I agree with you. Okay?
And I know nothing about spine. So, Dr. Chorluka with the hip spine syndrome.
Okay, it was a great introduction to this talk by Marco. Thank you, Marco. So
I'm always here for you.
yeah, to conclude this spinal session during today residence part of the Congress and FORTE course, I'll talk about something that is gaining popularity these days: hip spine syndrome and considerations about taking into account when you are doing something with a primary hip patient, that you must include spine into the consideration, and vice versa when spinal surgeon is assessing some kind of spinal pathology, must consider hip also. So my disclosures are here for the second time. We do have kinetic chain. Malfunction of any spinal segment have impact on adjacent segments, and shape of the spine directly influences on position and length of the legs, acetabular version and hip contractures, etc. So when you have problem somewhere in lumbar spine or hip joints or knee joints even, you must consider into account and to assess lumbar spine and all adjacent segments. There are a lot of differentials when you are assessing lumbopelvic pain syndromes. As this is spinal session, I'll say differentials of lumbopelvic pain syndromes. It can be sacroiliac pain, it can be muscle tear, it can be intra-articular hip pain, iliopsoas bursitis, femoral acetabular impingement, greater trochanteric bursitis, etc. You should always be aware on all of them. Then There is also possibility of peripheral nerve entrapment. So superior gluteal, inferior gluteal nerves, sciatic nerve, pudendal nerves, and posterior femoral cutaneous nerves can be entrapped and be referred as hip or low back pain. Also, there are some facet joint referred pain patterns, and as you can see on two right images, there are some overlapping between hip, especially and L3-4, and all of them 4-5-S1 also nerve roots. When we are comparing spine hip or hip spine syndrome, in spine hip syndrome, spine pathology is considered as primary pathology. Hip degeneration can be reactionary degeneration. In spine hip syndrome, at first we can have stiff pelvis, increased retroversion, abnormal kinematics in elderly especially, and bilateral hip involvement. And also in younger patients, you have lower cross syndrome. I'll show that on my next slide. In hip spine syndrome, there is hip pathology, which is primary origin of pain and the primary point of contact with a physician. And spine degeneration is reactionary. And it's mostly seen in predominantly in unilateral hip problems. Lower cross syndrome, why? We have, because all of lower cross syndrome in, primarily in younger patients, why it's gravity in matter. There is a weakness of the abdominal wall which acts as a restraint for the pelvic ring. So that's, and it's mostly patients for physical therapy, physiatrists, physical and rehabilitation specialists, physical therapy and rehabilitation specialists, and physical therapy. And now I'll come back to the cone of the economy. Mr. Dubuisset introduced this concept. The wider the cone, the more energy is required to remain upright. We are consuming a lot of energy if the base is really wide. And Roussoli told us that pelvic incidence is unchangeable and influences the shape of the entire spine. And Schwab told us that pelvic incidence must be equal to lumbar lordosis, and there is a tolerance about 10 degrees. All greater differences significantly affect ODI. ODI is Oswestry Disability Index. It's direct patient-reported measurement system that can reflect their disability and their degree of disability. The higher the degree, the surgery is much more needed. And any spondylosis or prior surgery, especially when you have flat back or failed back, may result in more LLPI mismatch and resulting in a final spinal imbalance. So when we have a diagnostic workup and differentials of hip spine or spine hip syndrome, we should perform clinical testing of weak and tight muscle groups. We should assess posture, gait abnormalities, range of motion, and characteristics of the pain. Pain can be radicular. It's in most cases it's very suggestive and it's with clear distribution of the dermatoma. But there is also pseudo-radicular pain, which is not so much suggestive. There is local pain on palpation or motion. Pseudo-radicular pain. Be aware of patients which have some kind of implants or something was done on their spine before, because pseudo-radicular pain can have some pattern of radicular pain, but you should ask more if there is some implants in the spine, because loose implants can produce pain that we say, okay, it's a pseudo-radicular pain. And also there is a referred or chronic neuropathic pain. Also, during the diagnostic workup, we should assess laboratory parameters. And we have to exclude any rheumatoid or systemic conditions. Radiological diagnostic workup, Mr. DRM has told us several times today, EOS. EOS is perfect tool. It's not so expensive, and it can give you a lot of information of your posture, and you can learn a lot from it. So these are extreme flexion extension and neutral radiographs of the lumbar spine. And flexion extension radiographs, they're not so fashionable these days. They are not so suggestive. They are not so usable, and they are not giving a lot of information. What can contribute to the spine hip or hip spine syndrome? From the spine based is sagittal imbalance, degenerative disc disease, spinal canal stenosis, and Bastrup sign. Does anybody know what the Bastrup sign is? Marco? Okay, food for thought. And from hip side, it can be acetabular version, acetabular dysplasia, femoral head dysplasia, and leg length discrepancy. So, how should we treat? It depends on expected changes in spinal geometry and pelvic parameters. Sometimes an elegant solution will permit the resolution of two problems at once. Existing of spine-hip syndrome doesn't mean that we must surgically treat both. For example, unilateral hip arthroplasty can resolve low back pain, but we should be very good before the surgery, very good in clinical assessment and in radiological workup. Also, sometimes maybe a high risk of primary total hip arthroplasty complications in patients with sagittal alignment, with malfunction, sagittal imbalance. Tough patient-reported outcomes are equally good. And we have a good Bordeaux classification, which you can find in this article, which can say more about spine-hip relations in patients with hip osteoarthritis, and then you can predict which patient will benefit from hip prosthesis or some kind of spinal procedure. And we must know that you are not putting implants in predefined positions, because if there is a high degree of deformity, it's not necessary to maximize your correction. If anatomy is already had some kind of deviance of normal, because patients and their muscles and soft tissues are used to live in some kind of forced posture. Overcorrection can reveal some other problems also. And food for thought, except Bastrup sign. There is no true treatment algorithms. There is only expert opinion. There is a wide spectrum of disease matters to consider making universal decision-making unlikely, and good understanding of the nature of degenerative cascades and the influence that treating one link has on the other links, and we have to make case-by-case careful consideration. So to conclude, because my time is up, the linkage of various body parts may lead to transfer of pathology. Treatment primarily focused on inciting events, where is the start of the degenerative cascade, and we need to radiographic workup, and we must eliminate all other potential symptomatic overlapping, and probably we may need to eventually address both in spine and hip issues, which is first, I think it's hip, because when you put the hip prosthesis, we can play around lumbar lordosis. But when we have lumbar lordosis fixed, hip is more demanding to put it into adequate position to prevent complications. And adequate treatment of one issue may cause significant reduction of symptoms of the other level, as I said previously. Thank you.
Okay, please stay there. As a hip surgeon, I would like to ask you a question, and I believe here are many people who are interested in hip arthroplasties. Which patients are at risk? Yes. Which patients are at risk for maybe dislocation of the hip? And if you were in my shoes, who would you send for additional spinal surgeon workup?
You must assess lumbar spine. If there is, when you see the patient from the door, you must assess the patient when he's walking into your office. If he have any postural deviance, you should assess him from the lumbar spine, at least from the lumbar spine. But EOS, if you have EOS, it's perfect to make it from the top. to the
Okay, and in which spine conditions would you recommend us to do more and less anteversion or retroversion?
there is no unique
of the stabular component?
there is no unique answer, because probably you'll put your hip arthroplasty perfectly according to that posture. But if he will undergo some spinal procedure with recreating lordosis, with some kind of realignment, that hip from perfect will become
anterior displaced.
catastrophic. Yeah.
Actually, that's the main problem in this situation. But because then you have either to do another version of 45 degrees as a hip surgeon, or then you have to do the constraints, the semi-constraints implants.
Yes.
It's actually, if you have a very, what Stipe said, if you have a very fixed spine, if your spine is fixed and you have fused it, and the spine surgeon has done like a fusion L2 to pelvis, and you have no other movement, then you have to play with your implants, and you have to do a big underversion, and then there's these lines, these radiographic lines, chi or something like that, where you measure the how much the femur is flexed or extended. But I don't know. I'm not a hip surgeon. I don't know if intraoperatively, because there are some degrees like up to 40 or to 45 degrees. How much can you measure your underversion during the operation to be like 45 or not, to be 40, not 35?
5 degrees slightly, but 10 degrees of anteversion, yeah. Definitely. Yeah. And as a hip surgeon, there is really good way of Ranavat that he showed really easily. When you look at the foramina obturatoria, if they are really narrow, so cat's eyes closed, maybe later we can show the photo. If there is an anterior tilt of the pelvis, then the cat's eyes are closed, yep, on the AP, and those patients are prone to posterior dislocation. Yeah. And then I would put maybe even 30, 35 degrees of anteversion. If you have a rigid spine, if you have somebody whose hip is retroverted, then on the AP, the foramina obturatoria are very circle-like, cat's eyes open. I would go with less, yeah, anteversion. I would even go to 0.
But it's only, yeah, it's
case by case.
Very much case by case. Yeah. There are some really great papers by Jonathan Vigdorchik, by Charles Riviere, by Ranavat, that you can read about that. When I first started reading about that, there is just so many things. You understand everything, and then you have to put into account when patient is standing and when patient is sitting. Yeah. That's even more complex. It's even more complex. So, yeah, yes. But when you sit down, your pelvis should retrovert. That increases the anteversion. That's more. Those patients are more prone to anterior dislocation. But this is just food for thought. Hip-spine relationship are a hot topic in the last 10 years, especially in the last 5 years.
What I think we all learned in a residency in our time was that hip goes first, and we always operated the hip before we operate the spine if both conditions need operation. Right now we have to think about it more, and that's what I think you and I have to decide as surgeons. Is it better to operate the spine first and then have a good retroverted pelvis so that you put a safe arthroplasty, or is it better to do the hip first? But then you cannot anticipate what I change in the spine surgery. That's the problem.
I would like if you finish your spine job first, and then I can play with anteversion. Right, yeah. Because it can happen that I put in a total hip arthroplasty. It works great. After 3 or 4 years, the patient has operated their spine, and then they start dislocating after 4 years. That's terrible. That's right.
But that's true if the spine is treated perfectly.
Yeah.
If there is any imbalance left, and we see a lot of that patients, especially in some neurosurgical settings, they are not assessing the balance, most of them.
I understand.
And you have fused spine in flat back, for example, and you say, okay, 3 years ago you had spine surgery, now you are safe for hypertrophy.
We still have to evaluate.
Yeah.
Maybe
There
we
is
can
no
finish
unique,
the discussion
yeah,
on the
okay.
coffee break. Professor Mineiro just arrived. Professor Mineiro, he's one of the great European surgeons, a spine surgeon, and actually a brain behind the EBOT. He is the man who knows most about EBOT in the world. And he will tell us some info about that. Before giving a word to Professor Mineiro, I would very much like to thank our host, Professor Stojka. Professor Stojka is the brain behind this session. He is the initiator of this. He gave us the topics, and he actually cares about knowledge and education. And there are very few surgeons in Europe who care this much. Thank you so much for inviting us and for creating this.
Thank you.
Professor Mineiro.
In relation to the last topic that you were mentioning, I think for most of you, you have to remember that the compensatory mechanisms of the degenerative spine, when they lose the lordosis, is rotating the pelvis. So if you do the hip first, and then you completely change the position of the pelvis, obviously, I mean, the likelihood of the dislocation or creating problems is one of them. But the other way around is that very often patients that have a flat back, so they complain of pain in the buttock and thigh, which is very often confused with symptoms from the hip. So ever so often in your doorstep, in your spine clinic, they come with both hips replaced and still the same pain, because the pain is not from the hips, but comes from the spine. So nowadays, as Vasilis was saying, in the past, it used to be pelvis first, spine second. Now I think it's the other way around. If they've got severe pathology in the spine and changing the balancing, the sagittal balance, examine the patient, but probably correct the spine first and then do the hips. That's my view as well, because of that situation of the wear and tear of the spine, of the hip, which is in the wrong position. So the likelihood of either dislocating or wearing out more quickly because it's not biomechanically in the right position, obviously that's going to fail. So I think we should examine first the patient and obviously look at the balance in the spine. It's not the sort of thing that I'm a hip surgeon, I don't have anything to do with the spine. No, the patient is the whole. So the responsibility is from the general orthopedic surgeon. So you cannot sort of kick and say, well, go and see somebody else. No, you must take the decision. But the decision must be taken based on the clinical findings, which I think is so important. As I was mentioning earlier on, the pressure on all of us from the administration is see patients quick because I want you to see more patients in the clinic. So more and more the pressure from the administrator is for you to take decisions based on the screen of the computer. Almost we don't have time to undress the patient. That's wrong. We have to match the decision on the clinical findings together with the investigation. So don't go by the administration and say, well, you should see 50 patients in one morning or instead of seeing only 20. No, that's wrong. You need time to make the right decision. Otherwise, you're operating on patients that probably don't need. How many people with degenerative spines have got dark disc disease? Many of us here. Nobody complains of back pain. Why operating on MRIs? No, you need to look at the patients. And I think that's so relevant to do that. And that's exactly what we've been discussing, one first or the other. Look at the patients. Listen to the patient. Examine the patient. Anyhow, what I'd like you to do is I'm just going to give you a quick view about one of the things which is called the INTRIN exam. And why is the INTRIN exam so relevant today? Well, the INTRIN exam is relevant because obviously there's a general certification, and you must change here, is a qualification in Europe that obviously is getting all around, and this is giving the standards of training around the different countries in Europe. Well, it is not automatic if you've got this qualification because it is not legally recognized in Europe has a qualification of training. Also, with the European board exam, you cannot go to one country and say, well, I'm a specialist under the European board and therefore I can work. Up to the moment, no. We hope that's going to be happening in the future. You've got urology, you've got anesthesiology, and other specialities that have given up their national boards in favor of the European boards. We hope that in the future this will happen in orthopedics, but not yet. Well, so there are two main domains of training, as you can see here. There is a general one, which is the one that is obviously in most of the training centers, in most of our departments, and then you've got the specialized one, which is the advanced one, and that's going to be run in certain departments where you can do your fellowships, but those are recognized by specialty societies. That's a different thing. We're not concerned about that in this particular exam. So this is the general exam that we are concerned with. So looking, how have we tried to help in order to improve the standards of the exam? Well, one of the things that we have done this interim exam, which I'm going to talk to you about, and the other issue is this very important, the EEP, European Education Platform. Many trainees and residents over the year have asked me and many of the examiners, how can I prepare myself for the exam? There's no book. People who were asking earlier on about the OKU for the United States. Well, we're different from the Americans. They are very good, but it's different. So it has to be based on the curriculum. And this EEP gives you exactly the curriculum and the areas that you should know. Is published in the internet, and you can follow it. Well, this is happening since the last year before the pandemic. Before the pandemic, we had nearly 1,500 candidates taking the interim exam in Europe. For instance, in France, it is compulsory to take the interim exam every year. In France, and the exam is in English. So that means how relevant. Now in Portugal, it is compulsory always to have the interim exam each year. And I'll show you why it is important. So because of the pandemic, the numbers came down, and this year we had 986, but it will increase again. And it's free of charge because it's sponsored by the European board. All right, the progress over the years. So when we've started in 2014, these were the countries in Europe that were taking the exam. Over the years, in 2017, the numbers have been increasing. And obviously, not only the number of candidates, but the number of hospitals have been increasing. Now we have 131 hospitals taking the exam.